Physical examination, auscultation, heart sounds. Heart sounds. Technique. Proper technique must be reviewed prior to discussing auscultatory findings. This involves patient positioning, areas of auscultation, and the stethoscope itself. In order to avoid missing subtle findings, cardiac auscultation must be performed with the patient in 3 different positions. These positions include sitting, supine, and left lateral decubitus. The sitting position is important for auscultation of sounds emanating from the base of the heart and great vessels, as well as pericardial valves and some tricuspid murmurs. Although most standard cardiac auscultation is performed with the patient supine, auscultation over the apex with the patient in the left lateral decubitus position brings out mitral murmurs and low-pitched cardiac sounds that might not be otherwise appreciated. 5 areas of auscultation have been classically described: mitral over the apical impulse, tricuspid, 5th intercostal space at the left parasternal line, 5th intercostal space at the left parasternal line, pulmonic, 2nd intercostal space at the left parasternal line, aortic, 2nd intercostal space at the right parasternal line, and accessory aortic area. Accessory aortic area, 3rd intercostal space at the left parasternal line. Accessory aortic area, 3rd intercostal space at the left parasternal line. However, the stethoscope should not jump from one area to the other. Instead, the examiner should march the stethoscope from the apex toward the sternum, then up along the parasternal line, ending at the right parasternal area at the level of the 2nd intercostal space. So, the stethoscope should not jump from one area to the other. Instead, the examiner should march the stethoscope from the apex toward the sternum, then up along the parasternal line, ending at the right parasternal area at the level of the 2nd intercostal space. With the patient sitting, the opposite is then performed using the right upper border at the starting point. This meticulous process ensures that abnormal auscultatory findings heard over a very localized area will not be missed, as they might if only the 5 main areas are auscultated. When indicated, auscultation should also be extended to areas where murmurs typically radiate, such as the left axilla, neck, suprasternal notch, right infraclavicular area, and back. In each area, careful attention must be paid to each heart sound, systole and diastole. The examiner should always take full advantage of the 2 parts of the stethoscope, the bell and the diaphragm. The bell is designed for auscultation of low-pitched sounds, 3rd and 4th heart sounds, diastolic rumble, vascular bruits, whereas the diaphragm should be used for most heart sounds and murmurs. The bell should be gently applied to the bare chest. If excessive pressure is exerted, the bell works as a diaphragm. The examiner, however, should also use this property in his or her favor. For example, in a patient with mitral stenosis, variable stethoscope pressure should be used to focus on the rumble, bell, or the opening snap diaphragm. Here the figure shows areas of auscultation. The 5 classic areas of cardiac auscultation: 1. Aortic, 2nd intercostal space at the parasternal line. 2. Pulmonic, 2nd intercostal space at the parasternal line. 3. Accessory aortic area, 3rd intercostal space at the left parasternal line. And 4. Tricuspid, 5th intercostal space at the left parasternal line. And 5. Mitral over the apical impulse. Now, first heart sound, normal first heart sound. The first heart sound corresponds to closure of the atrioventricular valves and therefore marks the end of diastole. It has 2 components, mitral and tricuspid. with the latter following the former in normal circumstances. In most patients, M1 overshadows T1 and S1 is heard as a single sound. Sometimes, however, both components can be heard over the left lower sternal border, causing splitting of first heart sound. This is a normal finding. Both components should have the same pitch and intensity and should be easily differentiated from a right-sided fourth heart sound, lower pitched and an early systolic click, higher pitched and usually auscultated in a much wider area. Splitting of first heart sound might be slightly more prominent in patients with a right bundle branch block. So splitting of first heart sound might be slightly more prominent in patients with a right bundle branch block. So splitting of first heart sound might be slightly more prominent in patients with a right bundle branch block. Now, abnormalities of the first heart sound. An increase in the intensity of the first heart sound can be encountered in situations where the PR interval is short, such as pre-excitation or tachycardia. Sinus tachycardia associated with hyperdynamic left ventricle is the most common cause of a loud first heart sound in clinical practice. Sinus tachycardia associated with a hyperdynamic left ventricle is the most common cause of a loud first heart sound in clinical practice. Mitral stenosis can lead to both increase and decrease in the intensity of first heart sound depending on degree of calcification and mobility of the valve. Leaflets. When mitral leaflets are pliable, the intensity of first heart sound is increased, and this might be the only sign of rheumatic involvement of the mitral valve. The finding of a loud first heart sound also has therapeutic implications because it suggests that the patient is likely a good candidate for percutaneous balloon or valvuloplasty. In cases where the leaflets are calcific and immobile, the first heart sound becomes soft. A decrease in the intensity of first heart sound is recognized in patients with prolonged PR interval or after long RR intervals. Diastolic periods in patients with atrial fibrillation. Given the wide variability of RR intervals in atrial fibrillation, first heart sound usually has variable intensity. Decreased first heart sound amplitude is also recognized in myopathic processes and in patients with severe reduction in systolic function due to a poorly contractile ventricle. Lastly, a soft first heart sound might also be observed in acute aortic regurgitation due to marked elevation in left ventricular diastolic pressures and early closure of the mitral valve. Most clinical abnormalities alter intensity of the M1 component of the first heart sound. An exception is the patient with Epstein anomaly, when the large cell-like anterior tricuspid leaflet gives rise to a loud T1 component. Second heart sound. Normal second heart sound. The second heart sound corresponds to closure of the semilunar valves and has an aortic and a pulmonary component. The S2 sound is high-pitched and best heard with the diaphragm. As opposed to first heart sound, its two components are audible in the majority of patients. The second heart sound intensity and timing carry very valuable diagnostic information. In order for the examiner to describe specific abnormalities of A2 and P2 or to ensure that normality is indeed present, it is mandatory that both components are simultaneously auscultated and actively sought. P2 is typically audible in a limited area over the second left intercostal space and is sometimes only appreciated with the patient sitting. Therefore, one can only state that a single S2 is present if appropriate auscultatory maneuvers are taken and a single component remains audible. In normal circumstances, both A2 and P2 should have similar intensities when auscultated simultaneously in the pulmonic position. A P2 should not be audible at other positions unless pulmonary hypertension is present. Physiologic splitting of second heart sound. During normal inspiration, there is enhanced venous return to right side cardiac chambers as well as increased capacitance in pulmonary vasculature. The combination of these two phenomena leads to an increase in right ventricular ejection time with inspiration and delay in closure of the pulmonary valve following inspiration. The normal lack of significant respirophasic change in left ventricular ejection time results in single audible S2 during expiration, P2 occurring simultaneously with A2, and two distinct components on inspiration with P2 following A2, so-called physiologic splitting of second heart sound. Now, abnormal splitting of second heart sound. Non-physiologic splitting of second heart sound can be categorized as paradoxical, persistent, or fixed. Paradoxical, persistent, or fixed. Paradoxical, persistent, or fixed. The abnormalities can be secondary to hemodynamic or conduction derangements. In paradoxical splitting of second heart sound, there is a delay in aortic valve closure with P2 preceding A2. Second heart sound is split during expiration and becomes single during inspiration as P2 becomes closer to A2. Hence the paradox, that is the opposite of normal. This delay in A2 is secondary to a prolongation of left ventricular ejection time, which can be due to increase in afterload or non-uniform contraction of left ventricle. Conduction abnormalities. The long ejection time can be measured from the duration of flow through the left ventricular outflow tract or across the aortic valve by Doppler echocardiography. It usually exceeds 300 milliseconds in these instances. Although classically described in valvular aortic stenosis, paradoxical splitting of the second heart sound is more common in obstructive hypertrophic cardiomyopathy. So paradoxical splitting of the second heart sound is more common in obstructive hypertrophic cardiomyopathy, suggesting severe dynamic left ventricular outflow obstruction. In severe aortic stenosis, the aortic A2 component is either absent or diminished, and splitting of second heart sound is rarely appreciated. In left bundle branch block, activation of left ventricular lateral wall is delayed. In LVBB, in left bundle branch block, activation of left ventricular lateral wall is delayed, also prolonging ejection period. This is a sign of left ventricular dysynchrony. And in our experience, patients with decreased left ventricular systolic function and paradoxical splitting of second heart sound appear to respond favorably to cardiac resynchronization therapy. Right ventricular pacing also promotes delayed activation of the left ventricle. And paradoxical splitting of second heart sound. In persistent splitting, second S2 is widely split at the baseline. Both A2 and P2 can be heard. But with inspiration, the A2-P2 interval becomes longer. This is secondary to an underlying delay in the occurrence of P2. Wide splitting of S2 therefore reflects abnormal right ventricular ejection hemodynamics. The most common cause in clinical practice is right bundle branch block, although severe increase afterload resulting from pulmonary hypertension can also lead to wide splitting of second heart sound. Fixed splitting of second heart sound is classically found in ostium secundum atrial septal defect, where wide splitting of second heart sound is present at baseline with minimal or no change in A2-P2 interval during inspiration. The wide S2 splitting on expiration is related to increased pulmonary vascular capacitance. Associated with increased pulmonary blood flow, delaying the P2 component. As a result of the interatrial communication, the decrease in venous return during expiration is compensated by an increase in left to right shunt without changes in right ventricular preload. The lack of significant respirophasic changes in both preload and afterload results in no change in right ventricular ejection period and therefore fixed A2-P2 interval. Now, abnormalities of second heart sound components. A loud P2 is a sign of pulmonary arterial hypertension in severe cases of pulmonary hypertension. P2 is palpable. P2 is generally heard over a small area in the left upper chest. A P2 component that can be auscultated in other areas is a clue that P2 is increased. In general, a P2 heard at the left lower sternal border indicates moderate pulmonary hypertension, and if audible at the apex indicates severe pulmonary hypertension. A diminished P2 is noted in patients with increased anteroposterior thoracic distance. The opposite is also true. Patients with diminished anteroposterior thoracic dimension, such as patients with pectus excavatum, can have an abnormally loud P2. In patients with obstructive lung disease, increased lung volume contributes to decrease in P2. This being the most common cause for a single S2 in practice. A diminished or absent P2 is also noted in patients with severe valvular pulmonary stenosis. Lastly, a single second heart sound is a characteristic clinical finding in patients with congenitally corrected transposition, where the posterior location of the pulmonary valve prevents auscultation of P2 component. A loud A2 is expected in patients with severe systemic arterial hypertension. A very loud A2, timbre-like, was also described in syphilitic aortitis, but the disease is almost rarely encountered nowadays. A diminished A2 is a classic finding of valvular calcific aortic stenosis and is also an important marker of disease severity, especially when the A2 component is absent. The presence of a normal A2 component in a patient with severe aortic stenosis and echo Doppler findings of fixed obstruction should prompt investigation for subaortic or supravalvular obstruction. This figure showing respirophasic A2-P2 intervals in physiologic and abnormal splitting of second heart sound. Physiologic splitting as first heart sound expiration A2-P2, first heart sound inspiration A2-P2 gap increases. In abnormal splitting, persistent splitting, first heart sound S1, in expiration there is A2-P2 divided. A2-P2 is delayed. There is delay between A2 and P2. Then inspiration S1 and A2-P2. Abnormal splitting, first heart sound, then P2-A2. Here is a reverse splitting of second heart sound. Paradoxical splitting of second heart sound. P2 followed by A2. Then first heart sound, and in inspiration P2-A2 is becoming a single heart sound. Here the figure showing auscultation findings in different stages of diastolic dysfunction. Left ventricular and left atrial pressure tracings, black, as well as mitral inflow Doppler pattern, blue. Mitral inflow Doppler pattern, blue, in different degrees of left atrial pressure elevation and diastolic dysfunction. Cardiac auscultation would reflect hemodynamic abnormalities and allows longitudinal assessment of filling pressures. Here is normal and abnormal relaxation, pseudo-normalization, restriction reversible, restriction reversible, restriction irreversible. Grade 1 is abnormal relaxation, grade 2 pseudo-normalization, grade 3 reversible restriction, grade 3 reversible restriction, grade 4 irreversible restriction. Mean left atrial pressure is NYHA class, and heart sound S4 is audible in grade 1, and S3 is audible in reversible restriction and irreversible restriction. Fourth heart sound. In the early phases of diastolic dysfunction, abnormal prolonged ventricular relaxation impairs early diastolic ventricular filling, decreasing the amount of filling in early diastole with a compensatory enhanced atrial contribution of diastolic filling. An audible left fourth heart sound. An audible left fourth heart sound represents this prominent, forceful left atrial contraction into a non-compliant left ventricle. It occurs therefore in late diastole, pre-systole, and is never present in atrial fibrillation. So it occurs therefore in late diastole, pre-systole, and is never present in atrial fibrillation. A left-sided S4 fourth heart sound is a low-pitched sound, typically only heard at the apex with the bell and easily missed if auscultation in the left lateral decubitus position is not performed. So a left-sided fourth heart sound is a low-pitched sound, typically only heard at the apex with the bell and easily missed if auscultation in the left lateral decubitus position is not performed. Doppler echocardiographic findings that correlate to the presence of an audible fourth heart sound are that of an abnormal relaxation pattern, grade 1 pattern, on the transmitral flow velocity curve, include a low EA ratio and a prolonged deceleration time with a shortened duration of the A wave. There are also increased atrial reversal velocities on pulmonary vein echo Doppler profiles. Left ventricular tracings will show a slow rate of fall of left ventricular pressure during isovolumic relaxation, reduced negative BP, lack of rapid filling waves, and prominent A waves. Patients with impaired ventricular relaxation typically have normal mean left atrial pressures and thus are not in heart failure at rest, but will develop shortness of breath with exertion as the diastolic filling period shortens. These patients rely on atrial contraction for diastolic filling, and thus loss of organized atrial contraction is generally poorly tolerated. Abnormal ventricular relaxation occurs most frequently with left ventricular hypertrophy due to aortic stenosis, hypertrophic cardiomyopathy, and systemic hypertension. It also occurs with ongoing myocardial ischemia and is frequently observed as part of aging. Thus, an audible fourth heart sound is expected in all those entities but should not be observed in young adults since myocardial relaxation is normal in that age group. A right-sided S4 is usually associated with right ventricular pressure overload, as seen in pulmonary hypertension, pulmonary stenosis, or early phases of restrictive cardiomyopathy. A right-sided fourth heart sound is usually heard at the left lower sternal border and increases with inspiration. Now, third heart sound. A third heart sound will occur when there is prominent early rapid ventricular filling during diastole. It is a low-pitched sound heard in early diastole, most likely due to tensing of the chordae as the left ventricle rapidly expands from the early filling. And S3 is best heard at the apex with the bell lightly placed and the patient in the left lateral decubitus position. It occurs 100 to 150 milliseconds after S2. It occurs 100 to 150 milliseconds after S2. This sound correlates with a high initial E velocity and increased EA ratio and short deceleration time on the transmitral flow velocity curve. There are a number of different etiologies for the generation of an S3. The most common is in a patient with an abnormal stiffness of the myocardium coupled with high filling pressures. The high left atrial pressure produces high driving pressure across the mitral valve to account for the early rapid filling, which is followed by a rapid increase in left ventricular diastolic pressure. This is manifested as a steep rapid filling wave on left ventricular pressures, tracing, and large left atrial V waves, reflecting the pressure rise as pulmonary venous blood enters an overloaded left atrium. And S3 can be a dynamic finding and usually dependent on the volume status of the patient. If there is severe elevation of left atrial pressure, there will be an S3 on auscultation with a restrictive pattern on the transmitral flow velocity curve, high EA ratio, and short deceleration time. However, with diuresis and lowering of the left atrial pressure, the transmitral flow pattern will change from a restrictive grade 3 pattern to pseudo-normal grade 2 pattern, and even delayed relaxation grade 1 pattern with disappearance of the S3 on examination. A persistent S3 despite treatment indicates the end stage of diastolic dysfunction. A persistent S3 despite treatment indicates the end stage of diastolic dysfunction, stage 4 pattern, caused by severe irreversible fibrosis of the myocardium. There are other etiologies for S3 on examination, all of which reflect rapid early diastolic filling. Rapid early diastolic filling occurs in young healthy hearts due to vigorous ventricular relaxation, which sucks the blood in from left atrium to left ventricle in early diastole, allowing for a higher preload while maintaining low to normal pressures. The transmitral Doppler velocity curve will have the same appearance as a restrictive filling pattern, high EA ratio and short deceleration time. However, the mitral annular motion will be enhanced, seen as a high E prime velocity on the Doppler tissue velocity curve. Thus, S3 are often noted in young individuals, athletes, and pregnant patients. Conversely, they are rarely observed in patients older than 40 years. The presence of an S3 in patients older than age 40 suggests organic heart disease. Constrictive pericarditis is also a form of severe diastolic heart failure where the scarred inelastic pericardium significantly impairs ventricular diastolic filling. Rapid filling waves on right and left ventricular hemodynamic tracings were some of the earliest hemodynamic signs of constrictive pericarditis described by cardiac catheterization. This prominent early diastolic filling is responsible for the pericardial knock. This prominent early diastolic filling is responsible for the pericardial knock heard in constrictive pericarditis. The knock tends to happen slightly earlier than the typical S3 and tends to have a higher pitch. High E wave velocities and rapid filling waves on ventricular tracings can also be seen in severe mitral regurgitation. These are secondary to the large volume of blood rapidly returning from left atrium to left ventricle in early diastole. This increased rapid early diastolic filling can produce a low-pitched filling sound in mitral regurgitation and is a key marker of severe mitral regurgitation. Although the findings described so far are related to left-sided etiologies, except for the pericardial knock, which is most likely originated from the right ventricle, the same rationale can be applied to right-sided lesions. A right-sided S3 can be heard in severe right ventricular diastolic dysfunction such as severe right-sided heart failure and restrictive cardiomyopathy. Filling sounds can also be heard in severe tricuspid regurgitation and may be the only finding on auscultation. The systolic murmur may be barely audible due to equalization of the right atrial and right ventricular pressures during systole. Inspiration will enhance the intensity of the right-sided S3 and S4.